Okay, thanks for submitting your images of DVT and heart. They were really quite good. So let's go over the ones I selected that you'll learn the most from and that were your best images. So I have my pointer on. There we go. I think this is site 1, and I think I remember coming over and helping you all find that site 1 was a lot more superior than you thought that it was. And then you found this image. I seem to remember this. So this would be the femoral vein, nice and big and round and anechoic, and then the femoral artery. So if the femoral artery is on the right side of the screen, we know that this is the patient's left leg, because remember the navel nerve, artery, vein, lymphatic, and so that the nerve and the artery are most lateral. So if this is most lateral, then this has to be the left side, and then the patient's medial side is here. So this is a very good still image of that. If it's possible that this was site 3 and this is the arterial bifurcation, but I can't tell from the still image. But since these are so large, I think this is probably site 1. But nice job there. This is site 2. This is your Mickey Mouse. Beautiful job. This is the classic site 2 site that we want to see. It's really, really nice. So this would be your common femoral vein, nice and big and round. And this is the left side. So this is the common femoral artery. It has not bifurcated yet. And then this is the greater saphenous vein, or the large saphenous vein, coming off, and then it will be going medially. So beautiful job catching this. Very nice. This is site 3. You got a nice cine loop of it. It's really beautiful. You can see the 2 arteries here and a little bit of the perforator when you do compression. The common femoral vein, it hasn't bifurcated yet, so it is just the single vein. And you can see that perforator just going right in between the bifurcated arteries. Beautiful job of catching these structures. That's the classic image that we want to get with all of those structures in there, especially the perforator. Really nice job. The only suggestion that I would make is you don't quite have full compression there. So one of the suggestions I would make is that if you're not getting full compression and you really do think that you have, can I catch this? Yeah, there we go. That you have this vessel over here, say my finger right here, that you're not quite catching, you're going to rock like that and then press down so that you get full compression there. So we don't quite have full compression there. I think it's just a technical thing, but that's just an example of, in order to have a purely, truly good image for interpretation, proof there's no DVT, especially in that common femoral vein that hasn't bifurcated yet. It's a big vein. You wouldn't want to have a clot in there. You need to make sure that you do that nice rocking motion to get over that vessel so you can completely compress it if possible. Really beautiful job catching the structures. We didn't catch site 4, which would be all 4 vessels, the bifurcation of the artery and the vein. That's okay. But this is site 5, where it's just the femoral vein and the femoral artery. And remember, the femoral vein will be posterior. This is anterior, this is this is anterior, this is posterior. So the posterior vessel will be the vein, nice and big and anechoic. And then more circular with thicker walls is the artery. So with compression, this is the one that should completely collapse. If it doesn't, especially as you go down the thigh and it's changing positions, use that same rocking technique to make sure you get that vessel compressed posteriorly. Additionally, if you can't get good compression, you want to use counter compression with your hand on the posterior part of the patient's thigh, and then you definitely know that you did everything you could to compress the vein. And if it didn't, then that would be a DVT. Nice job. Moving on to your heart images. This is your subxiphoid heart. I know it's subxiphoid because I can see beautiful liver here, and I see the shoe print and the left atrium, the gnome's hat, and a little bit of the right when it comes in and out. The reason why it's flopping in and out is you did that beautiful maneuver of having the patient take a deep breath in, which brings the heart down closer to your probe. But it does require then to adjust the angle of your probe as when the patient breathes in and out, you'd have to do different angles, which you did. So you were able to see very clearly each ventricle as the patient is breathing in. You can see that right ventricle really well, the interventricular septum, shoe print, and the right atrium, and the inner atrial septum, and the pericardium. So you would be able to determine whether or not there was a pericardial effusion or tamponade. You would be able to tell if it was a cardiac arrest, a megacode that you were running. You would be able to tell whether or not in this view there was organized cardiac activity during the pulse check. So really nice job, and nice job using that maneuver. This is your parasternal long axis view. It's a little fuzzy, so you might not recognize it as the classic view. It's fuzzy because the depth is too deep. We're down to almost 16 centimeters. So in the parasternal long axis, it's not as deep as when we're getting the subxiphoid view or the apical 4 view, because you're mostly just the subxiphoid view, because you're so far away from the heart in the subxiphoid view. So you want to adjust your depth to around 12, 13, and that would get rid of this extra space. And one of the reasons why this area isn't as clear as we'd like is partially the depth, but also remember, when you have fluid-filled structures, the sound beam doesn't wane, so it doesn't attenuate as much, so it hits the posterior structures with more strength. So you get all this posterior enhancement, which we don't really want here, because we want to be able to see this left ventricular wall, the free wall, very clearly. We want to see the left atrium, which is right here. So you would get a clear image. This is really, really nice positioning of the parasternal long axis. I'll show you the structures that I can see because I know to look for them. This is the interventricular septum. You get a good view of it right here. And then the whole left ventricle has that nice tapered shape that you want. That's the anterior leaflet and the posterior leaflet of the mitral valve. And you can see that that's, if you look carefully, that anterior leaflet is hitting the interventricular septum. So this would be the left atrium. This is the aortic valve. It looks like a little bit of a peach. And then this is the right ventricle up here. So we can't see the descending aorta, which is usually right here, because of the posterior enhancement. So how you would fix that is first change the depth so it's shallow, more shallow, and then use your gain, tap the screen and tap the 3 bars, which is your timed gain compensation, and make sure that the lower bar, you make it darker. So you lower the gain so that you make this darker down here, and then you would see the descending aorta, and it would be picture perfect. You were exactly in the right spot. Just a couple of image optimizations that would give you this beautiful view. So nice job. So this is a still of your apical 4, and it's nice to look at it in a still. I can tell it's your apical 4 and not your subxiphoid because we see some possibly liver there, but the angle is more vertical than the traditional subxiphoid. We usually will see much more of the liver because, again, we're so far away in the subxiphoid. So there are a couple of reasons why we would want to make this clear that this is an apical 4. And the way that we would do it is this interventricular septum, in the ideal image of an apical 4 chamber view, should be completely vertical from the apex. So this one's veering a little bit to the right. This is a common thing that happens when we're first learning to scan the apical 4 chamber view. So I'm going to go to the next slide and show you exactly what happened and how you would correct it. Okay, So why your interventricular septum was veering a bit to the right side of the image rather than straight up and down was because your probe was probably right here, and imaging more of the side of the right ventricle, which is right here. So that would give you that angle. So to correct that, what you're going to do is take the tail and swing laterally, and you're also going to, that repositions the probe so that the scan head is right at the apex. So it's just a lateral move by swinging the tail and letting the scan head move laterally right to the PMI, or the apex of the heart. And that way you can see that the interventricular septum, which is right here, will be straight up and down. So it will look like that. So that's how you correct that. And that's how you know it's definitely an apical 4 and not somewhere in between an apical 4 and a subxiphoid view. But really, really nice job with your images.